Welcome to Empowering Plans, a show dedicated to identifying waste and undue expense in the health benefits industry, discovering ways to maximize benefits while minimizing costs, and empowering employers, administrators, and consultants to emphasize, once again, the benefit in benefit plan. Today's episode is brought to you by the FIA Group, empowering plans since 1999. Now here are your hosts, the FIA Group's own CEO, Adam Russo, and Senior Vice President and General Counsel, Ron Peck.
Hello, everybody, and welcome to another episode of Empowering Plans with the FIA Group. I am your host, Adam Russo, co-founder and CEO of the FIA Group, and with me back from missing one episode. People lost it online, Ron. They were freaked out. Like, where's Ron? Did Ron lose his job? Ron is still here. He's gainfully employed. Welcome back, Ron Peck. Hello, Ron.
Thank you. And I do want to make a point of pointing out the fact that Brady is not here. I actually kicked him out for trying to fill my seat.
You know, Brady sat in your chair and did not want to leave after that last podcast, Ron. I just want to let you know. So, folks, today we are supposed to talk about reference-based pricing. What's out there, all the different myths, what's good about it, what's bad about it, why is it happening, is it really happening? But I guess today is a big deal. It looks like we're not in the path of totality, as some would call it. We are just in Boston. But I guess 90% of the sun is going to be covered up today, Ron. And I guess, should we shut down the office and tell everyone to go outside and look up straight at the sun and go blind? Is that what's going to happen today?
I think it's the signs of the end of times, Adam. First, I'm not here for a podcast. Next, the sun is blotted out. Who knows what's going to happen next?
So tomorrow, are we going to hear online, like on CNN, like that tens of thousands of people have gone blind? Is that what's going to happen?
Yes, that's exactly what's going to happen.
Are you not supposed to look up at the sun today, right?
I don't think you're ever supposed to look up at the sun.
Folks, you're going to hear it here first. I will look straight up for 5 seconds and just see what happens. My wife said I will have sunspots. I'll let you know by the next podcast episode. So, reference-based pricing. Ron, what's going on? Why are we talking about it? All I know is this. Last week, Ron and I spent a couple days in beautiful Texas. Folks, I love Texas. However, when we got out of that airport in Dallas, it felt like a gigantic blow dryer was literally blowing on both of us. I said to myself, how in the world can anyone live here in August? It was 4 o'clock in the afternoon, and I thought I was going to die.
It was warm, Adam. It was very warm.
Warm. I'll take a blizzard over that any day of the week. At least with a blizzard, you can put a jacket on.
Absolutely.
So, Ron, what's going on with RBP?
Sure. So I think when reference-based pricing, Medicare-based pricing, all these innovative sort of anti-network, network replacing, repricing type methodologies first came out, you really started to see a burst in growth maybe a couple decades ago and then a decade ago, but it sort of plateaued for a while. I think there were still a lot of entities in our industry that had a theory or a thought that legislature, the regulators, law was somehow going to fix the high cost of healthcare, that they were going to pass laws that were going to cap how much hospitals could charge, for instance. And I think what we're starting to see now between the ACA and now what's happening in D.C. under Trump's administration is people are finally starting to come to the realization that D.C. and the state lawmakers are not going to address the actual cost of healthcare. They're not going to pass laws that are going to cap what hospitals can charge. And if you, as a benefit plan or third-party administrator or broker or advisor or vendor, want to actually impact the cost of care, you're going to have to do it yourself. And that's where reference-based pricing is starting to come in.
So about RBP, as we like to call it for short, here's the reality. For every 100 calls we get from either a broker or a plan or an administrator about reference-based pricing, I would say that one plan actually does it. That's right now. But however, it's still a lot more plans are doing it, are moving to it, especially in certain states, than ever before. There's no question about it. But I think what's important is when I hear people say, oh, we're doing reference-based pricing, to me, it's I want to have a follow-up question, but I just hold myself back and I just, clench my teeth. What type of reference-based pricing? There's all different kinds. There's all different vendors. Each vendor, this is not like you're doing, writing a plan where you can hire a lawyer to write a plan. The next thing's going to be what type of plan? Mech plan, skinny plan, a wrap network plan, fully insured plan. People think when you say the word RBP that it's all the same. But it's not. They're very different. And I think we should spend a little bit of time today talking about the differences and how do you get to those points.
Sure. It's funny. I think a lot of people think reference-based pricing is synonymous with Medicare-based pricing, but we know from our experience that Medicare is just one of many different references you can use. And, you add in the issue that, okay, let's say I have a benefit plan. We cover some sort of treatment, let's say a pediatric care, that Medicare doesn't have a price. Well, if you're doing just Medicare-based pricing, then you're kind of in a pickle because you don't know how am I going to reprice this claim. Whereas with other forms of reference-based pricing, you come up with things like Medicare comparable or other references, things like average wholesale, MSRP, area. And what's funny is, Adam, and you've mentioned this in the past, and I liked it when I heard it the first time, you mentioned at one point that even traditional out-of-network UNC language, where you're basing it on what other providers in the area charge, technically that's reference-based pricing too. You're referencing what providers in the area charge.
See what Ron always does? He always gets into the weeds, right? Like there's people listening in that are hearing average wholesale price, average wholesale costs, cost to charge ratios, and they're lost, all right? So I know that's what Ron and I would do on a Thursday afternoon over a beer. We're going to talk about these things like that. But let's just take it a step back. Reference-based pricing. At the end of the day, there are a couple options. One, right now your plan has a network, a normal PPO network. What could you do? First, one, just do reference-based pricing on only your out-of-network claims. That's the first type of RBP plan that you can do.
Training wheels.
Now, right, training wheels. Why do we bring this up? First, people make a jump. 90% of the usual, customary, and reasonable language, UNC, UCNR, RNC, whatever you want to call it, folks, is horrible. 9 out of 10 of you listening, and there's probably 10 people listening, so 9 of you, your UNC language basically says we're going to pay on out-of-network claims whatever the hospital wants. That's it. So to take a leap from that to, we need to make it at Medicare rate is a big difference. There's a lot you could do in between. But that's first, just out of network. Second, reference-based pricing only for hospital claims. Ron, what percentage of claims you think are hospital claims? Think about your own life. What percentage of the time? Well, maybe you go to the hospital a lot, Ron. Maybe you're a bad example. But what do you think typically? What percentage of the claims out there are hospital claims?
Well, I do like breakfast in bed, Adam, and that's the only time I can get it. But that being
you can go to a Hilton.
That's true. It's funny. Sometimes people use the 80-20 rule or the 90-10 rule. I think here we're talking about like the 99-1 rule, Adam.
All right. So you could have reference-based pricing just for hospital claims, and all the other claims have a physician-only network or some kind of network, right? Third is we're going to do reference-based pricing on everything, on that flu shot, when you go in for that rash on your arm, or anywhere on your body. The bottom line is every single claim, no matter what it is, there's no deal, there's no contract, there's nothing. We're going to pay you a reference-based pricing rate. Now, folks, on those three options, when people say, well, we have very low balance billing, there's no noise. We've had no problem with our reference-based pricing plan. Don't you think it matters what type of RBP plan you actually put in place? Which of those three that I said did you put in place? If it's only for hospital claims, and as Ron said, it's 1% of all your claims, obviously 99% of your claims have no issues. But the problem is that's not the fact. The fact are, based on the type of plan you have, then you got to look at what you're doing about the noise. Ron?
Sure. So, Adam, you've brought up a couple things already. One is, what are you reference-based pricing versus what are you contracting or networking? Two is, what kind of reference are you actually using? You mentioned the one who uses Medicare plus nothing additional. If you're paying just Medicare rates, expect balance billing. If you pay 300% Medicare, I got a feeling you won't see much balance billing. But then once you set in your rules, you start running it, it's going, now people are going to be balance billed. And if someone tells you there is no balance billing, don't believe it. One,
there is
balance
a possibility.
billing happens.
There is a possibility there's no balance billing if they are paying Medicare plus 300%.
Right, that's
so then
true.
Obviously the hospital's like, hey, wait a second, I just got more money than I even charged.
Yeah, my reference-based pricing is whatever the charge is, I pay that. So
right.
Yeah, with that kind of case, you're not going to be billed that. But in most situations where you're paying less than the provider wants, they're going to have to balance bill. And the thing is, how you address it matters, because not only is that going to impact peace and quiet at the employer's office, but it's also going to impact future deals with that facility. Because if they get burnt by you once, they may blackball your employees, they may stop treating your members. So how you deal with balance billing, it's not only dealing with that individual bill, but how you're going to deal with that facility long term.
Exactly. It also depends on where you're located. So, for example, if you are in Texas, or if you're in a state like Florida, or you're in a state like Ohio, where more and more hospitals are now accepting reference-based pricing as an actual payment option, if you have a plan where you're going to pay the hospital a set price for RBP, and the patient has no coinsurance. There is no copay. There is no deductible. Now that hospital says, hey, wait a second. We're going to get all the money from the plan. We don't have to go after the patient at all for anything. That's going to cut back on my expenses from a collection standpoint. My billing department has way less work. It depends on where you're located, how many different hospitals are there in your town. If it's a one-hospital town and you want to reimburse them the Medicare rate plus 10%, you're probably going to have a lot of issues. You're probably going to have a lot of noise. But it comes down to this. Let's just say there is noise. Let's just say there is balanced billing. What the plan does, what the administrator does, and what your vendor does matters. So we talk about it all the time, Ron. There's patient advocacy, there's patient defense, and there's plan defense. Those are three very different things. So you always want to ask your vendor, you always want to ask your administrator what they're actually doing. Patient advocacy is just that. It's a person on the phone helping, holding the patient's hand, trying to get a claim resolved, talking to the facilities, talking to the doctors, talking to the billing office to try to make a deal on a case or to make sure that that balance bill goes away.
And with patient advocacy, they're also educating the patient, which I think is a key issue that a lot of plans miss. People get balance billed. They think, hey, I thought I have insurance for this. If they didn't know that there was the possibility they'd be balance billed ahead of time and they don't know what steps they're supposed to take in case of balance bill, somebody has failed. And speaking of education, I know we just saw that article that one facility, a hospital, lost its 501c3 rights because they were violating 501R. They weren't providing the proper steps for financial aid to the patients. If a patient takes advantage of those rights, those 501R rights, and really drives it home, and you potentially see this kind of impact where a hospital loses its 501c3 status, that's a result of true patient education and advocacy.
So the next step is plan defense. Now, to me, this is the easiest of the three. If your plan doc is well written and you're not going around or going against any state mandates or federal laws, if you have a plan document that tells you specifically how much the plan is going to pay, and the data that particular plan or administrator uses can back up the proof that you actually paid the claim in that fashion, the plan's defense is pretty solid right there. Good plan language and actually having data to back up your payment opportunities. Plan defense. The third one that people have a lot of issues with, and I don't want to get into the whole conflict potential, Ron. I just want to look at patient defense. What is it and how's it done?
Sure. So this is at the point where patient advocacy has failed. The patient needs legal representation, and they're going to mount a defense. And that defense probably will push back against the provider, question the provider's charges. Potentially, you're going to file some sort of declaratory action and try to get the provider to expose its pricing methodologies in open court. And again, defend your rights legally to avoid the balance bill or force the provider to prove the validity of that balance.
And this is where I urge all of you, if you decide to have a patient defense, look at the actual contracts that you're signing. Because many times, even on patient advocacy, you'll find in the fine print on the contract that, well, we're not going to get involved and help the patient either from an advocacy standpoint or a defense standpoint unless a certain dollar threshold is met. So if the balance bill is $50, we're not going to get involved unless it's $10,000. Well, I tell this story all the time. If my mom received a balance bill today for $400, she's freaked out. How am I going to pay my groceries? How am I going to pay my electric bill? If she got a balance bill for $400,000, she's laughing. She's throwing it in the trash. Like, obviously, that can't be real. So the point is, most of the noise that we see are for claims under $1,000. So when you have a firm or an administrator or someone say to you, don't worry about patient balance billing. Don't worry about it. We have the advocacy. We have the defense. Great. But at what point, at what dollar point are they then getting involved?
Adam, the number one reason I see reference-based pricing fails is exactly like you say. It's death by 1,000 paper cuts. That's absolutely the fate.
Very good. I like that one, Ron.
And we'll use it in the future.
So instead of one big giant gash, a bunch of little paper cuts, eventually you're going to bleed to death. So the point is, we actually had a client who sent us over 100 cases because nothing was being done on their balance bill cases, on the balance bill defense work. 100. 97 of them were under $1,000. With a few phone calls, we resolved all of them. But that's where a lot of these plans die. That's where a lot of these reference-based pricing plans don't make it to year 2, where they actually go fully insured instead of being self-funded, is because they don't have an answer to a $500 balance bill. And let's face it, guys, hospitals and facilities, they're not dumb. They know that they could probably get a $500 balance bill. they know they're probably not going to get a $50,000 balance bill from that patient unless they got a lot of money. So again, I know we're not spending a whole bunch of time. We don't have that much time to talk about all the intricacies of RBP. But folks, it's not all the same as we definitely have made alluded to. So a couple points before we go. First, data. Know where the data is coming from and that you can validate what the data is telling you. There's been plenty of lawsuits over the years of people using data that doesn't make any sense. It's undercharged, undervalued, etc. First. Two, your plan docs. They have to be aligned. The fact that we see reference-based pricing plans that don't actually have plan docs created yet scares the living you-know-what out of me. Next, figure out what type of RBP you want. All your claims, some of your claims, or only out-of-network claims. 4, the defense. Do you want them to defend the patient, defend just the plan, patient advocacy, and at what dollar point? But last but not least is the pricing options. There are 2 different ways different vendors get paid. You're either paying a % of bill charges or you're paying a PEPM rate. Whatever you decide to do, at least make sure that you're getting your money's worth based on the type of defenses, based on the plan design, and the type of data you're going to have access to. Ron?
Well said. I think that you've pretty much nailed it when you talk about reference-based pricing, preparation, management, after effect. Cover the whole timeline.
Well, I know we have a couple questions, but we only have time for one. And the first question I got is what we always get. Who is the best reference-based pricing firm out there? Folks, I'm not going to answer that question unless someone wants to pay me $1 million to put their logo on my arm like a soccer jersey. I'm not going to say. All I would tell you is just read all the contracts, look what's out there, and you will be able to find a good quality vendor that's right for you. There's no question about it. That's all the time we have for today. Hopefully, Ron, we all still can see in the 2 weeks when we have the next podcast. I hope everyone enjoys today's eclipse. On behalf of Ron Peck and myself, we hope you continue to empower your plans. Thank you.
Thank you.